Hello, my name is Axel Grothey. I'm a GI medical oncologist at West Cancer Center and Research Institute in Germantown, Tennessee. I'm here with a very esteemed panel to give updates on GI malignancy in 2020, an exciting year where it's not only COVID happened, but we saw a lot of advances in GI malignancies. And I'm here with Dr. Eng, Dr. Soares, and Dr. George, Manju George. And I would like everyone to introduce herself. Cathy?
My name is Dr. Cathy Eng. I'm here at Vanderbilt Ingram Cancer Center, head of GI research. I'm in Nashville, Tennessee.
Hi, I'm Heloisa Soares. I am a GI medical oncology and NET expert physician at Huntsman Cancer Institute at the University of Utah. Thank you for having me.
Hi, I'm Manju George. I'm a rectal cancer survivor. I'm also the scientific director at Colontown. Colontown is an online international colorectal cancer patient and caregiver support and education community. Happy to be here.
Great, perfect. So the way this will work, we'll kind of break up GI malignancies in different parts, have an introductory presentation, then a short discussion, and eventually, we'll see all this again wrapped up from a patient perspective. And I think it's going to be very exciting. Okay, so I'd like to talk about advances in upper GI malignancies, gastroesophageal cancer, and HCC. And a lot of the upper GI new data actually came at ESMO. So this will be very heavily referring to the recent ESMO meeting. So these are my disclosures. When we talk about the exciting field of immuno-oncology, we have seen FDA approval for pembrolizumab, nivolumab, atezolizumab-based therapy in various indications across the GI world, in various lines of therapy, sometimes linked to a certain biomarker, tumor marker, like the CPS score. But you can see that there are a lot of still empty boxes that are not filled yet, where we'd like to see approval and good data, of course, for immune therapies. And the first and second line gastroesophageal adenocarcinoma arena was actually blank, or had been blank until recently. And now we have data that are really exciting and will set a new standard of care for IO therapy in upper GI malignancies. When we evaluate these immune checkpoint inhibitors and trials in upper GI cancers, there are certain facts that we need to consider. First of all, does the trial and does the agent work in squamous cell cancers and or adenocarcinomas, esophageal cancers versus gastroesophageal malignancies or gastric cancers? Then very important attention has to be paid to how are PD-L1 expression levels determined? Is it a scoring system, the comprehensive scoring system like the CPS score, which looks at its PD-L expression levels in immune cells and in tumor cells, or is it just focusing on tumor cells? And what is the cutoff of positivity, a score of 10, 5, 1, or all comers? And then when we look at the trial population, it's very important to look at Asian versus non-Asian patient population, because we do know in particular gastric cancer has a different biology in Asian patients. So until recently, until ESMO 2020, the kind of the scorecard of trials, in particular randomized trials in upper GI malignancies, was not that, let's say, positive. We've seen data in green here of trials that either non-randomized trials or Asian trials, randomized phase 3 trials, the ATTRACTION study, that were positive in 2017. But after that, we have seen repeated trials that were negative. The Keynote 61 trial, 62 trial, the Javelin trials were all negative. And it was kind of a sobering experience for some time, until in particular this one study here, the Checkmate 649 study came about, which investigated the use of nivolumab plus oxaliplatin-based chemotherapy in first-line advanced gastric esophageal or esophageal adenocarcinoma. Important here, adenocarcinoma. And one of the other important factors is this was a study that looked at patients with a CPS PD-L1 score of 5 and higher. That's a scoring system that a lot of the pembrolizumab studies had used and was now adopted for the first time for a nivolumab study. So large study more than 1,400 patients, nivolumab added to either CAPOX or FOLFOX, or CAPOX or FOLFOX first-line treatment, which I think is really what we commonly use as one of the standards of care in first-line treatment. And importantly, 75% of patients were actually non-Asian, and very few patients had MSI-high tumors, equal in both arms, because we do know, of course, that MSI-high is a predictor for immune checkpoint inhibitor activity. Primary endpoint was overall survival was nicely reached with a hazard ratio of 0.71, with an improvement in median overall survival of 3.3 months, the first time really that we have seen in a non-HER2 positive patient population, in a non-Asian patient population, a median overall survival of over 14 months. And this was for a patient population with CPS scores of 5 and higher. They did provide additional analysis of CPS 1 and higher, or all randomized patients, including the CPS negative tumors. And you can see that the hazard ratio attenuates over time. We have not yet seen a breakout for patients, between, let's say, 0 and 1, 1 and 5, etc. So this remains to be seen how we can extend this finding actually to other patient population, to the low CPS patient population. In the subgroup analysis here, forest plot, really not one group stood out as not benefiting significantly in duration response, and response rate was higher and longer with the addition of nivolumab to chemotherapy, 60% response rate. And again, the durability of response is very nice. Now, interestingly, there was a second study, very similar design, the ATTRACTION-4 study, also presented at ESMO. Here, an Asian patient population, Japan, Korea, Taiwan, very similar design, nivolumab added to an oxaliplatin-based therapy, either as 1 plus oxaliplatin or capecitabine plus oxaliplatin. And progression-free survival, one of the endpoints was reached. The survival improvement was reached with a hazard ratio of 0.68, but the overall survival, in contrast to the Checkmate study, was not reached as endpoint. But admittedly, you need to look at the data here. Median overall survival was 17 months longer than in the, let's say, Western Checkmate study. So this identifies, again, there's a different biology, different treatment approaches toward gastric cancer, higher response rate as seen before in the first-line nivolumab FOLFOX CAPOX study, and durability of response, again, higher. So there was actually very nice discussion at ESMO by Lizzie Smith about, how can we put this into perspective? These trials, Checkmate 649 and ATTRACTION-4, were different. Patient population had, in some ways, different, similar outcomes for progression-free survival, response rate. The overall survival difference was only found in Checkmate 649, not in ATTRACTION. But one of the reasons why I believe we're looking at the difference in survival is that a lot more patients in ATTRACTION-4 were able to go from control arm crossover to immunotherapy. So it was a now or later access to the IO therapy, not a now or never access to IO therapy. This is definitely could have kind of mitigated the difference in overall survival. So the take-home message from my perspective, and I hope the FDA will look at this too, patients with PD-L1 CPS score of 5 and higher gastric cancer treated with adenocarcinoma, treated with an oxaliplatin, fluoropyrimidine, and nivolumab can now expect a longer survival than ever seen before, and should represent a new standard of care. Now, going along the lines of improvements with IO therapy in upper GI malignancies, Keynote 590 looked at pembrolizumab first line added to chemotherapy in advanced esophageal cancer. Here the randomization, so chemotherapy backbone here was 5-FU cisplatin, one of those international standards of care. A dual primary endpoint of overall survival and progression-free survival. You can see here that there was a 50-50 split between Asian patients and non-Asian patients, dominant squamous cell cancers, and 50% of patients actually had a very high CPS score of 10 and above, which was actually the primary endpoint of the primary patient population of the study. For esophageal squamous cell cancers with the high CPS scores, you can see there is a significant improvement in overall survival, hazard ratio of 0.57, highly statistically significant p-value. If you look at the overall, all CPS scores, squamous cell cancers, again, statistically significant. So the histology squamous cell cancer is really something that dominates our approach here. When you look at all patients combined, including the adenocarcinomas, you can see still CPS score patients, a clearly positive disease, a positive result, and including even lower CPS score patients, again, overall survival benefit for the addition of pembrolizumab to chemotherapy. But when you look at the breakdown in the forest plot, you can see that the CPS score is really something that we have to pay attention to, because patients who had a lower CPS score, less than 10, did not benefit as much. You see the hazard ratio, the confidence interval overlap, but reassuringly adenocarcinomas and squamous cell cancers in the overall survival analysis and had the same benefit. So durability of response and response rate, again, very common theme as before, higher for the addition of pembrolizumab to chemotherapy. Now, to kind of go back into the idea of what else can we see with esophageal cancer and GE junction cancer following neoadjuvant chemoradiation therapy and surgery, kind of the triplet approach that we commonly use in the United States as standard of care for esophageal and GE junction adenocarcinoma. Checkmate 577 investigated a very interesting question about, should we give additional adjuvant treatment in patients who do not have a pathological complete response with the trimodality therapy, meaning chemoradiation therapy followed by surgery? So these patients here, a global study, 2-to-1 randomization, more than almost 800 patients had gone through trimodality therapy and had pathologic residual disease of some minor degree, actually T1 or N1 disease, and they were randomized to nivolumab or placebo, and nivolumab was continued for a total duration of up to a year. And this is something we had tried to investigate with chemotherapy. Do we need additional chemotherapy after surgery when we see that we don't have complete response? But chemotherapy is very difficult to administer in these patients after esophagectomy. Now, this was a patient population mainly non-Asian, mainly adenocarcinoma, and actually with low PD-L1 expression level on the tumor. This is not the CPS score, this is tumor PD-L1 expression levels. So pretty much I think the patient population that we commonly see in our clinical practice. And I think these data are quite dramatic when you look at the median disease-free survival, overall survival data had not been reported yet, of a doubling from 11 months to 22 months, highly statistically significant results with a hazard ratio of 0.69. So this is, I think, really going to inform our standard of care. And you can see here that adenocarcinomas and squamous cell cancers both actually benefited squamous cell cancers as expected to a larger degree. So take-home message from the esophageal cancer studies, metastatic and early stage and advanced metastatic esophageal cancer with a CPS score of 10, potentially with a lower score, not quite solid yet. Pembrolizumab plus platinum and fluoropyrimidine is now standard of care. And I do believe that the adjuvant nivolumab data after resection with residual cancer with prior radiochemotherapy in esophageal gastric cancers can also be considered standard of care. So we have a lot new standards of care in upper GI malignancies with the use of nivolumab and pembrolizumab in various settings. Now, switching gear to liver cancer, and I just want to highlight, liver cancer is one of the more common and most deadly cancers that we have worldwide. We're expecting about 1 million deaths by 2030. You know that the geographic distribution is different. And this review article in 2019 had one interesting figure, which I use for educational purposes actually quite a bit. It shows the estimated number of deaths compared to the estimated number of incident cases for various different malignancies. And you can see if a tumor is kind of on this orange line that I just plotted here, lethality and incidence is more or less 100%. You can see that liver cancer, pancreas cancer, esophageal cancer, brain cancer, gallbladder cancer, very close to this ominous figure, whereas breast cancer, colorectal cancer, prostate cancer have much better prognosis. Liver cancer is a cancer of an unmet need. And we classify liver cancer in various different classification system, the Barcelona classification of liver cancer, the BCLC, looks at HCC from a treatment strategy perspective. What we're commonly focusing on when we talk about treatment options is the intermediate stage and advanced stage for local regional therapies and for systemic treatments. And the systemic treatments in options in HCC have really exploded in the last years. In 2008, we had sorafenib, and it's kind of the only treatment option for about a decade. And now we have lenvatinib as part of the first-line treatment approach before the era of immuno-oncology, then second-line treatment options, as you can see here, and even third-line treatment options with cabozantinib. Now, the IO arena, again, there wasn't necessarily a success story for some time. There was an interesting study, second-line pembrolizumab versus best supportive care in unresectable HCC. They kind of split the alpha between PFS and overall survival. That's why even though these curves look different compared to best supportive care and should indicate a benefit for pembrolizumab, it was not statistically significant. So by definition, this was a negative trial, even against placebo or best supportive care in this setting. So the Checkmate 4 and 5/9 study was first-line nivolumab compared to sorafenib, has not yet been published. We all expected the study to be positive, but no difference, no statistically significant in overall survival. So nivolumab and pembrolizumab in randomized comparison could not beat neither best supportive care nor first-line sorafenib. And you can see here progression-free survival, again, no big difference. Now, along came the IMbrave 150 study, which was published in New England Journal this year, which looked at a combination of atezolizumab, a PD-L1 antibody, plus bevacizumab, a VEGF inhibitor, which has immune modulatory components, 2-to-1 randomization against sorafenib, first-line treatment. Important to note here, there was a lot of stratification factors, and every single patient had an EGD to rule out clinically relevant varices, because everyone was concerned about potential bleeding with bevacizumab. Primary endpoint was overall survival, co-primary with PFS. You can see this is clinically meaningful. There is the difference that we wanted to see with a hazard ratio of 0.58 for overall survival, admittedly with a shorter follow-up than I would have liked it to see, but these curves separate nicely and they stay separated. And really virtually all subgroups here benefit, in particular patients with, let's say, more advanced cancers like BCLC stage C. Co-primary endpoint progression-free survival highlights what we've seen. This is an active combination, atezolizumab plus bevacizumab. Response rates were higher. Initially, when we heard about atezolizumab, we saw a response rate in single-arm studies up to 60%. Naturally, this attenuated over time in more randomized trials now here, but confirmed response rate of about 30% is something that we cannot achieve with sorafenib. Reassuringly also, it is better tolerated. Safety events were a lot less, serious events were less frequent. AEs were not as severe. So sorafenib, which we all know is not an easy agent to give, clearly had a worse toxicity profile than atezolizumab, bevacizumab. And they give authors credit for the fact that they also looked at patient-reported outcomes, and time to deterioration of quality of life was actually longer compared with atezolizumab, bevacizumab compared to sorafenib. So this opened the door for a lot of studies combining VEGF inhibitors plus IO therapy. There are several other interesting combination therapies. I think one of the more interesting ones is lenvatinib plus pembrolizumab in patients with HCC. This was a single-arm study with a large expansion cohort, and you can see that the waterfall plot here is quite interesting. I mean, these are waterfall plots we have not seen before in HCC. This combination is currently being investigated in a randomized phase 3 study. Another combination, this is my last study that I'd like to show you, is a combination of durvalumab, a PD-L1 inhibitor with a CTLA-4 antibody, just tremelimumab, just given, for instance, as one dose to prime the immune system and T cells. You can see here that the combination was associated with a very interesting long median overall survival of more than 18 months. So this study, this combination is actually being tested right now in the Himalaya study, phase 3, durvalumab, durva-tremi against arafenib in first line. So the treatment options in unresectable HCC have actually quite increased. And it's kind of, I borrowed this from Ghassan Abu Alfa. It's kind of the idea of I have a -1 line of therapy with atezolizumab-bev, and then you kind of potentially go down the old sequence of events. You might actually now have a total of 4 lines of therapy. Who would have thought that in HCC? So conclusion in my last slide here, Atezo-BEV in HCC has really emerged as standard of care in first-line treatment, has received FDA approval. Combination of lenvatinib plus pembro is very interesting. Multi-kinase inhibitors and ramucirumab is now shifted down the line, the old standards of care. Exciting times in the arena of HCC. So this is my last slide, and I will stop sharing and would like anyone's opinion about this. I mean, could I get my excitement about the developments across, how interesting it is to see IO therapy now really emerge as the standard of care in various indications?
Yeah, thank you, Dr. Grothey. It was an excellent presentation. I have to say, seeing the data in the G-junction esophageal cancer, with chemoradiation and then surgery and then resection with residual disease, pathological, I already started to incorporate that in my practice. I had just submitted a request to give nivolumab, and I'm waiting to see if that's going to be approved. Can you share, have you had a chance to have this sort of presentation in the clinic and see if your experience based on the data before the official, hopefully, FDA approval?
Yeah, so we had actually, I presented it, I gave an ESMO update, and everyone was quite intrigued, especially about the nivolumab question, the scenario that you just mentioned. And I think it ties into the idea, something that we want to explore. Do these immune checkpoint inhibitors might work better in, let's say, less, in low volume disease and, or neoadjuvant, I think there, Cathy will probably know more about rectal cancer, neoadjuvant IO therapy treatment options. We have an adjuvant trial ongoing in the cooperative group system with the Atomic study. So can we cure more patients? So I like this study actually to see whether we go from a palliative arena, in the curative aspect when we use it in earlier lines of earlier kind of treatment settings. Cathy, what do you think? I mean, I know you're working on rectal cancer, neoadjuvant IO therapy.
Yeah, no, I fully agree with you. I mean, obviously, I think there's a huge interest of trying to move this treatment forward in the treatment care plan to see if it provides additional benefit and potentially for some patients, depending upon the setting, it may potentially avoid surgical resection in some cases. But that's a long shot, but obviously it's something we're reaching for. So I find it really intriguing, the most recent data this year. It's fascinating.
Yeah, and Manju, I know there's a lot of excitement in the patient advocacy community about IO therapies, earlier lines of treatments, combination therapy, not just in upper GI, but also in colorectal cancer. And I know you'll talk about this later. And but any comments when you see the upper GI data right now?
I think that with the pembro approval, with MSS CRC, we have some patients in our groups where, they have qualified because their TMB is above 15, and we have seen some good responses. So I think that after all the initial, lot of trials with immunotherapy alone in the MSS, group with nothing encouraging, this is actually, especially use of immunotherapy in that select population with the higher TMB and seeing good results, it's encouraging to all the patients.
No, definitely. It's one of those hot topics. It's IO therapy, ctDNA, it's a lot going on right now. Okay, we'll have a discussion later, and also the implication of everything we talk about in the era of COVID. We need to tie this into a hot topic in 2020, but let's go on and go a little bit further down the GI track to Dr. Soares and her presentation. Heloisa, do you want to give us your presentation? Hepatobiliary, pancreas, neuroendocrine, a lot to talk about. Biliary, not hepato.
Right, thank you very much. As a big responsibility to follow you, and I definitely don't have as good looking slides, but I'll do my best. Thank you. These are my disclosures. So first of all, I want to talk about the FDA approvals this year, and I think it's such an excitement time to be treating biliary tract cholangiocarcinoma if you are a GI oncologist and as a patient, because we have so many more options. So back in April of 2020, the FDA actually approved FGFR2 inhibitor for second-line treatment of cholangiocarcinomas, and this was the announcement. So why this is important? More and more we know that cholangiocarcinomas are actually becoming quite target therapy approach, particularly in later lines of treatment. You can see here all the biliary tract tumors and all the mutations, and you can see when you look at the in the intrahepatic cholangiocarcinomas, there's lots of mutations that we can potentially target. The ones that I think we're focusing more in terms of research right now is the FGFR fusions, mutations, and amplifications, as well as IDH1 and 2 mutations, and so forth. We also have a number of patients that have BRAF-V6 mutation that we can actually potentially offer treatments based on the Aurora study. But for the purpose of this presentation, we're going to talk about this approval. So the FIGHT-2 study was presented actually on last year during ESMO. It was this multi-center open-label single-arm study that was enrolling patients that have histological, cytological diagnosis of locally advanced or metastatic cholangiocarcinoma. They had to have the documented alteration in the FGF or FGFR status. The patients to be enrolling in the study had to have at least one line of prior treatment, ECOG performance status of 2 or less, and they have to have adequate renal and hepatic function. So once the patients are identified, actually the FGFR status was then confirmed by a central lab, a clear central lab. And once it was confirmed, patients were divided in three different groups: the patients that had FGFR2 fusion or rearrangement versus the ones that had other FGFR alterations, and there was a smaller group that had no FGFR alterations. The primary endpoint of this phase 2 study was actually overall response rate, and patients received oral pemigatinib at a starting dose of 13.5 milligrams daily on a 21-day cycle of 2 weeks on, 1 week off. This was the trial profile. I don't mean to go into details, but I just want to focus here on the group with the FGFR2 rearrangements and fusions. They received was about out of the 1,206 patients that were pre-screened, they found that 9% of the patients, or 107, had these rearrangements. In terms of outcomes, I should mention that in terms of the demographics, the groups of all the patients that received were fairly similar. The median age of the patients was between late 50s to early 80s, to early 60 years old of age, and the groups were fairly balanced. And then when we look at the response rates, and particularly in the ones with the FGFR2 fusions or rearrangements, we see that 35% of the patients had objective response. There were 3% of the patients that had a complete response, and then 32% of the patients that had partial responses, and about close to half of the patients had stable disease. We saw much less in terms of objective response with the other groups. And here there is just another figure to show you the best percentage of change compared to the initial image in terms of responses. As you can see, that there's a nice group of patients that really obtain reduction in the tumor sizes. In terms of other outcomes, the median progression survival of these patients that have the FGFR2 mutations or rearrangements was about 6.9 months, and the overall survival, median overall survival were about 21 months, which is actually quite good. And when you compare these patients with the groups that had no rearrangements or a different rearrangements, they did much better. In terms of toxicity, The most common toxicity with this medication, and I'm going to make a point here just because it's a new medication that we have to some extent learn how to manage the side effects, was hyperphosphatemia, which was seen in about, at least in about 55% of the patients. Alopecia, diarrhea was also seen, fatigue, stomatitis, dry mouth, and dry eyes, as well as issues with sort of hand and foot syndrome and nail issues that you can see here in the pictures. So how do we manage the side effects? And I think this is also important for physicians, but also for patients to know. In terms of the hyperphosphatemia, diet modifications with eliminations of foods which has a high phosphate, managing the constipation and keeping hydration, potentially using phosphate lowering medications with the phosphate binders could be used. And for the ocular toxicity, having eye exams frequently is important, and also considering using artificial tears. For the hand and foot syndrome, using topical moisturizers or urea-based creams, also changing the frequency of the medication if needed, comfortable shoes and soft socks. And for the dry skin, again, moisturizing with lotion, the skin is important. And for the nail toxicity, something that I learned from to some extent, even talking to patients, is about using white vinegar and water soaks and a lot of nail care to manage the side effects. And again, this is important because we're going to see more of these FGFR inhibitors coming to practice. There are several that are under investigation, and this was the first one that has been approved. So I think it's good to mention that. So now I'm going to jump to pancreatic cancer. And even though we didn't have necessarily a new drug that was approved for pancreatic cancer this year, I think there was a lot of excitement during ASCO. And I'm going to here report some of the results from the SWOG 1505 study, which actually addressed the role of perioperative chemotherapy with modified FOLFIRINOX versus gemcitabine and nab-paclitaxel for patients with actually resectable pancreatic adenocarcinoma. Just a little bit in terms of background, just doing resection and adjuvant chemotherapy tends to have only modest outcomes in patients with pancreatic cancer. We know that unfortunately this disease tends to come back after resection and adjuvant treatment. And we feel that from the get-go that this is a disease that is considered much more of a systemic disease, if I may. So doing neoadjuvant treatment makes sense because it will hopefully have an early control of the systemic disease, improve the delivery of the chemotherapy, and also if the biology of the disease is bad from the get-go, this might be able to identify patients that will progress regardless of what you do, and you don't subject these patients to large surgery. In terms of the eligibility criteria for this study, they included resectable pancreatic adenocarcinomas with no prior cancer history. In terms of the resecability criteria, I have it here. They had to have less than 180 interface with the portal and superior mesenteric veins, which is a little bit different from the NCCN definition. And obviously no lesions that were concerning for metastatic disease and a good performance status. This is how the study was designed. Patients were identified. And then they were randomized to either modify FOLFIRINOX or gemcitabine nab-paclitaxel for about 3 months. After the treatment, they were restaged, and then if there was no progression, they were then referred to surgery. And after that, they will continue the same treatments for in the quote-unquote adjuvant setting. I must mention that the dose here of the irinotecan was initially 180 milligrams per square meter. And in the adjuvant setting, we use 150, just as a side note. In terms of the design, this was a randomized phase 2 study. The primary endpoint was 2 years overall survival and was a pick the winner design. First comparing the 2 years overall survival of each arm against a historical control. And then if the overall survival in 2 years were higher than 58%, then the arms will be compared against each other. This is the eligibility criteria. Initially, 147 patients were enrolled. and there were some patients that were considered to be ineligible for this study. So the final results is for about 102 patients. Baseline characteristics fairly similar, with the exception that the gem nab-paclitaxel arm had a more balance in terms of gender compared to the modified FOLFIRINOX, which is interesting because we have some data that gender might play a role in response to chemotherapy. In terms of what happens to the patients, so after they were randomized to their treatments, you can see here that 2 patients, or 4%, actually progressed during modified FOLFIRINOX, and here this number was a little bit higher at 15% or 7 patients. And in the end, FOLFIRINOX, 49% of the patients completed post-op chemotherapy versus 40 with the gemcitabine nab-paclitaxel. These are the adverse events, nothing in terms of major surprises. The ones that we typically pay more attention are febrile neutropenia and diarrhea. This is the 2 years overall survival that was the primary endpoint. We can see that none of these arms actually achieve that target. And when we look here, the modified FOLFIRINOX at 2 years was 43%, and then gem nab-paclitaxel was 46.9%, and the median overall survivals were very similar. When we look at surgical results, complete resection was 25% in the modified FOLFIRINOX versus 42% in the gem nab-paclitaxel arm, and disease-free survival after resection was 10 months versus 14 months. I apologize. So the conclusion, the primary endpoint was not met, so this 2 arms shouldn't be necessarily compared against each other. I think both modified FOLFIRINOX and gem nab-paclitaxel have similar efficacy with very acceptable safety and resectable rates. Here you'll see the table again, the 2 years overall survival and the median overall survival that can be very similar. And I think there was really good trial to also prove the principle that we can enroll patients in the, if I may, almost like this TNT, or at least neoadjuvant approach for pancreatic cancer prior to patients going to resections. The other study that I think is important to highlight is the SPAC-5F, which was a 4-arm study looking into the role of neoadjuvant treatment in patients with borderline resectable pancreatic cancer. These are the design of the trial. You can see 4 arms. Patients were either taken directly to surgery or received GemCap, which is gemcitabine capecitabine, or FOLFIRINOX, or chemoradiation. Then after the treatment, they were restaged, and then if no progression, they were taken to surgery, and then they received adjuvant treatment afterwards. Interesting enough, the presentation did not, the presenter did not went into the details of what type of adjuvant treatment the patients received afterwards, so I won't be able to comment on that. And the recruitment rate and resection rate were the primary endpoints. Here's the baseline characteristics of the patients. I just found interesting that there is more diabetes in the FOLFIRINOX arm, and they were also never smokers. There were the only few things that were there was a slightly imbalance. In terms of attempts to not undergo surgery, progression was seen in 12% of the patients with immediate surgery. GemCap was 25%. In the FOLFIRINOX arm was only 10%, and then in the chemoradiation arm was actually 31%, but granted a small number of patients per group. In terms of when you look at the patients that achieve resection, and things were fairly similar here with the, and it's interesting to see that there's a good number of patients in the chemoradiation arm that actually achieve R0 resection. I think it's also important to see that in most of the groups, the patients were able to complete adjuvant treatment, which is important because we always feel that these patients, after they go into surgical resection, they might not be able to accomplish that, but they were able in this study. Here, when we look at the tumor characteristics of the patients that were evaluated, you can see that all of them have treated tumors, a little bit less again in the chemoradiation arm, which is puzzling, and also perhaps a little bit more negative nodes too. When you look at the primary outcomes in terms of resection, there was no difference between upfront resection versus the neoadjuvant approach. And here again, oops. When you look at the R0 resections, even though there was more R0 resections with the neoadjuvant approach, that was not statistically significant. Side effects, I think adverse events were not different than what we expected. When we look at overall survival, you can see that patients that receive neoadjuvant therapy have a longer overall survival. And if you look at the 12 months, was big difference, 77% versus 42% for the patients that underwent immediate surgery. And you can see here there's a lot of patients that unfortunately will die in the first 4 months after undergoing surgery. So again, bringing the point that perhaps doing neoadjuvant therapy can help you with selection of these patients and selection for bad biology. This is a breakdown according to all the different treatments, and FOLFIRINOX here certainly give us good results, as well as gemcitabine and capecitabine. So the conclusions here, oops. The conclusions here are that there was no statistical difference between resection up front versus neoadjuvant therapy. However, there was a benefit in 1 year survival that we can see. And among all the treatments, FOLFIRINOX was the one that gave the patients the most benefit in this small study. Obviously comes with a little bit of more toxicity that we are very well aware, but is also very manageable. And it reinforces the idea that neoadjuvant therapy should be considered for patients that have borderline resectable pancreatic cancer. So I think the take-home message from these two studies that both gemcitabine and nab-paclitaxel, as well as FOLFIRINOX, are promising neoadjuvant treatments. Chemotherapy with radiation combination appears less appealing, but maybe there is a role if you want to quote unquote sterilize the field and downsize tumors. I think that's something that needs to be developed more. Gemcitabine and nab-paclitaxel had a complete response in some of the resectable patients from the first study, from the 1505, which is intriguing. It was that because there was a favorable biology selection. And I think the Alliance study, which is a cooperative group study here in the US, which is the 021806, will address the role for FOLFIRINOX in the neoadjuvant setting, which is a study that was activated this year and is enrolling. This is a take-home message that I think might be useful, and then was presented last past ASCO by Dr. Garrido, who is actually a colleague here at the University of Utah. So he feels that this is how he will approach resectable and perhaps borderline resectable in the future. If patients are fit for FOLFIRINOX, and definitely if they're younger than 70, talk to your surgeon, and then there's not necessarily anything wrong with going for surgery up front, because we have good data of modified FOLFIRINOX in the adjuvant setting if you feel that they can do. But particularly if patients have a high CA19-9 and they're younger, consideration for neoadjuvant chemotherapy for the upfront resectable will be important. And then after they undergo to surgery, it remains the question, what's the best adjuvant approach afterwards? For now, I think for most of the patients, we'll continue with modified FOLFIRINOX. Patients that are unfit for surgery, if they're less than 75, and they go for surgery up front, then if they have R0 resection doing GEM-CAPE can be an option. And if they have an R1 resection, gemcitabine, capecitabine becomes a little bit less appealing, because when you dissect the data that has been presented in the adjuvant setting, patients with R1 resections have less of a benefit. And that will be a perfect opportunity for a clinical trial. If they actually underwent chemotherapy up front and they go to surgery, the data that we have so far doesn't necessarily suggest that nab-paclitaxel and Gemzar would be useful outside of this context of the 1505, and I don't know if necessarily will be paid by the insurance, but if it could be an option as well. So with that, I will stop and we can discuss a little bit more. I'll be very interested to see how you treat your patients with upfront resectable and borderline resectable cases in pancreatic cancer. Thank you.
Yeah, thank you, Dr. Soares. It's great. So coming back to the initial presentation, to the biliary cancers, I think this is one of those highlights where I believe, this emphasizes we need to really profile cancer, GI cancers up front, and get a better understanding about, what's there. One of my fellows actually, I watched him, when he communicated to a patient, he said, we want to find the Achilles heel of a cancer. And I like that because it's kind of, I think, very instructive because there are cancers that have the FGFR fusion Achilles heel. And, it's actually quite interesting because I have a patient with on pemigatinib right now, and he got a profile actually a year and a half ago and went through his normal lines of therapy. And this FGFR fusion was not highlighted as actionable. When we get our molecular profiling thing, you have the highlights, and then and then when pemigatinib got approved, I actually got a call from the company saying, hey, by the way, you have a patient who has this fusion. And I went back to the report and I had missed it because it was not highlighted. It was not like, and of course we didn't know, we didn't have a drug, but now he's on pemigatinib and his tumor marker after, a month it's actually went down 50%. So I hope there is some response and he's tolerating it well. But I think anyone else who wants to highlight, where do you put your molecular profiling into the use of, in the management of patients? Upfront, at progression, is it last line, kind of the last thing that you throw at patients? What do you think?
Up front for me. First thing I do as soon as I meet the patient. And
yeah.
I know you and I have been on various discussions that just in case by chance the tissue takes forever, I will go ahead and order a molecular analysis, even by blood. Just I want to have something.
Yeah.
Yeah, same. The metastatic setting, when they come for the first consultation, I already order. Now we're even having trials moving to target therapy up front in the first line. So the sooner we get it, the better.
Or even adjuvant. I mean, I can easily see,
yes.
This opens the door for adjuvant treatments. Manju, I know there's a lot of interest from the patient community also to really figure out what's driving this cancer. And, I think comprehensive molecular profiling with all the Medicare approvals and everything that we're seeing is here, right?
Yes. So what we have done, we have started something called the Colentown University. So what we're doing there is that we are advertising the different tests that people can use. And so this becomes a source for patients to go and find out, there are sample reports, there is information telling them like, where does it fit? Like some of the tests, like if you're doing Tempest, or Foundation One or Garden 360, like what would be a good time to do it, and information. So patients are finding it really useful. This is our way of trying to make sure that, patients have access to the information that then they can discuss with their doctors.
So do you hear any issues about coverage? I mean, insurance coverage, cost for patients? Is there something you hear?
So what we have noticed is that when companies have these tests first, a lot of them are willing to do it for free for patients. So I can talk from personal experience that I had a Garden 360 and I never got a bill at all. And then I have had 2 Signatera tests, and that too, I haven't got a bill yet. So we are seeing that that's the case for a lot of patients, but now that they've got Medicare coverage, I don't know how that's going to change.
Yeah, I was going to say you have to be careful because it depends upon how your hospital bills the patient. So, so even though you may not have received a bill now, there may be a potential in the future. So you just have to be very careful and wherever the patient is, please talk to the doctor, please talk to the billing first, just to make sure they don't end up with a really large bill at the end of the day.
Right, right.
Yeah.
I mean, it is still something which I am happy to see that in the US we have access to these tests more readily than almost anywhere else in the world. And that's something we should not forget. Although I hear that the UK NHS right now is actually embracing comprehensive molecular profiling. So a socialized healthcare system can do that too if you set priorities. And I think that's important too. Yeah.
I think, Axel, it's important, as you know, also because there's so many different companies competing, they do have different pros and cons for each company.
Right, right. Okay.
From the patient side, we actually ask them to make sure that they talk to the company and make sure that they are not getting a giant bill. So, and they have some patient financial services assistance and things like that. So that's another thing.
To the pancreas cancer part, Heloisa, which you very nicely presented, I think the trend is toward total TNT or neoadjuvant therapies. I think that's a trend we've seen all across GI malignancies, and rightfully so. I think this is really where we make a best headway into earlier stage disease, resectability, counteracting bad tumor biology, also learning from our treatment approaches, and it's drug development, targeted therapy development. It's much more intriguing to me than having surgery up front and then treating a black box, like you don't know what's happening. You just treat 100 patients and you don't know who benefits, who doesn't. I think it's much more attractive to do neoadjuvant therapy.
I have a question for you. Are you treating with whatever your backbone that you decided? Are you doing typically 3 to 4 months, or you're trying to go for a whole 6 months up front for pancreas?
So pancreas, we virtually every patient, even with resectable disease, is more or less forced by our surgeon to get neoadjuvant therapy. Our surgeons are very much believers in the chemotherapy aspect. I believe in the surgery to some degree, but and so we use 4 cycles of FOLFIRINOX and get a scan and see the response, quality of response. And also, you check your C99 levels, which I believe play a role in monitoring, the neoadjuvant treatment. And then sometimes you have to switch to gem nab-paclitaxel, and I believe there are some patients actually respond to FOLFIRINOX and some patients respond to gem nab-paclitaxel. I mean, you really want to refine the patient population that eventually goes to surgery, not to eliminate those patients who have this rapidly progressive disease, because we see that too. I mean, I see patients who go through neoadjuvant treatment and come up with a liver metastasis, and this would not be a patient who should have gone to surgery. So kind of a test of time is important. And we discuss every single patient really in our NDT. I mean, I think that is a critical point. You need to really have the surgeon on board. And admittedly, we sometimes even use radiation therapy, although radiation therapy in pancreas cancer is like a dirty word, Anyway, I think for time's sake, we need to move on. Cathy, now get us into the lower part of the GI tract.
Thanks so much for asking me to join this group. It's my pleasure to participate. So in the interest of time, I'm going to be just touching base upon lower GI cancers, colorectal, and anal carcinoma. And to everyone out there, please note that I am post-clinic, and that's why I'm dressed like this, so I apologize. But I hope you are here to learn from what we can learn from this year in regards to these malignancies. So just to highlight, these are the aspects of colon cancer I will be discussing, as well as rectal cancer and anal carcinoma, just very briefly. In regards to metastatic colon cancer, I think many of you are familiar with the fact that for MSI-high tumors, for previously treated MSI-high tumors, pembrolizumab and nivolumab and ipilimumab have been approved in the previously treated setting. But now we have this phase 3 clinical trial that has been completed in treatment-naive patients. This was presented at this year's ASCO and updated again at this year's ESMO, looking at a 1-to-1 randomization of pembrolizumab at 200 milligrams Q3 weeks versus the investigator's choice of chemotherapy. And the primary endpoints were both progression-free survival and overall survival. The secondary endpoints was overall response rate. And the patients were assessed after 2 months of treatment with diagnostic imaging. And this was the primary endpoint that's been reported thus far. And as you can see here, in regards to 12-month rate of PFS, it was improved for pembrolizumab as a single agent versus standard chemotherapy at both 12 months and 24 months. I think, as many of you know, this was quite interesting though, because up until the 12-month rate, you can see here there's an overlap of the KM curves. And that obviously brings up some additional questions. Once again, this is the first report of this analysis that's been completing looking at PFS as the primary endpoint. There is some data to look to suggest that for those patients with RAS mutant tumors, based upon the forest plots, that they appear to possibly benefit a little bit more from the chemotherapy. But once again, overall, the primary endpoint was fulfilled. And the duration of response was quite high, as you can see here at 24 months, 83% of patients still had a very durable response. So it was quite impressive. At this year's ASCO, we also had an update regarding the phase 3 Beacon study, which was specifically for BRAF mutant patients. As many of you know, patients with the BRAF mutation historically have a very poor prognosis. And this trial looked at basically a 3-arm study with a 1-to-1-to-1 randomization, looking at the triplet of encorafenib plus binimetinib, which is a MEK inhibitor, plus cetuximab, versus the doublet of encorafenib plus cetuximab, or standard chemotherapy, which involved FOLFIRI plus cetuximab or irinotecan plus cetuximab. And the primary endpoint for this trial was overall survival, and the patients had to have had at least 1 or 2 prior regimens. So this was the original report that was published in New England Journal of Medicine in 2019, looking at the triplet of encorafenib, binimetinib, and cetuximab. And the overall survival was 9 months versus the control arm, which was standard chemotherapy. Now, please keep in mind that the triplet was not powered to be compared to the doublet. The study was basically powered to compare each of the investigational arms to the control arms. So here the triplet was superior at 9 months versus 5.4 months for the control arm. And the doublet of encorafenib with cetuximab ended up being quite surprisingly favorable at 8.4 months versus the control arm of standard chemotherapy. It was also noted that the response rate was slightly higher in the triplet arm of 26%, and for the doublet, 20%. There was some data to show that if you had had less therapy as well, there appeared to be a higher response rate for that patient population, meaning if you had received less prior therapies before initiating treatment. At this year's ASCO, we had an update regarding the triplet once again versus the doublet, and these were the surprising results. And in fact, this was at the ASCO GI Symposium, which was also tied into a quality of life analysis. So some of this may have been missed by others, and this should be out in publication soon. So basically here, the updated results show that the triplet has 9.3 months versus the control arm of 5.9 months. And in fact, the doublet of encorafenib and cetuximab was just as good at 9.3 months versus 5.9 months. And as a result of this, now the doublet is now considered the standard of care for patients with previously treated BRAF mutant colorectal cancer. And here just basically gives you an idea of how much they are similar. Basically, the KM curves overlay each other for the triplet and the doublet. And then in regards to PFS here, you can see the triplet was 4.5 months versus 1.5 months for the control arm. And for the doublet, 4.3 months versus 1.5 months again. So once again, in favor of encorafenib and cetuximab as a new standard of care for BRAF mutant metastatic colorectal cancer that have received at least 1 prior line of therapy. Now, just for interest, Dr. Grothey, as you know, is an expert in metastatic colorectal cancer, and he actually completed the single-arm phase 2 study looking at the triplet because of its promising results early on in Beacon. And this was a single-arm phase 2 study, once again, the BRAF mutant patient population, but this was a treatment-naive patient population. And this was reported at this year's ESMO, and the PFS here for approximately 40 patients was 4.9 months, and the response rate was about 50%. So Obviously, I think we're hoping for a little bit longer PFS, obviously, for treatment-naive patient population. But I think this was an important study because I think it answered the question that we were always wondering, is the triplet even better if we move it up front? Now, you should be aware that there is an ongoing or about to be open phase 3 trial that will hopefully answer some of the questions left over from both Beacon and obviously the thought process of moving the BRAF combination up front. And that should be open up this fall. And it's looking at the doublet versus the doublet with chemotherapy versus standard chemotherapy. And it will enroll up to almost 900 patients. Once again, the treatment-naive BRAF mutant patient population. It's called Breakwater. Now, to focus on another interesting subset of patients, I just thought I would highlight this because although this trial was originally reported earlier, this trial is ongoing and it's going to be moving likely into a phase 3 study. So this is looking at trastuzumab and tucatinib, which is an oral small molecule for HER2 in combination. This was a single arm study looking at patients specifically that were naive to Herceptin or trastuzumab, and these were the initial results. And this is known as the Mountaineer trial, which is actually a trial that is currently ongoing. To provide you some additional information, obviously HER2 amplification is actually even rarer than the BRAF mutation. It's approximately between 3 to 4% of the patient population with metastatic colorectal cancer. So this was the study results. These were the demographics. Small study that was reported initially. Once again, these are the initial results. Basically, the majority of patients had left-sided tumors. ECOG-PS of 0 to 1 was required. In regards to HER2 positivity by IHC, that was in 38% of patients, and 61% of patients had HER2 amplification. And these were the results. Of those 23 patients, the response rate was very high at 52.2%. And so that was quite impressive. The PFS was 8.1 months and the median OS was 18.7 months. So this is obviously very intriguing and a very promising treatment option for patients that are HER2 amplified or 3+ by IHC. And once again, this trial is currently enrolling at this time. Once again, here are the results for PFS and OS. Now, there's another drug that I think is very interesting that was reported at this year's ASCO. And this is an antibody drug conjugate. This is deruxtecan, which is basically an anti-HER2 IgG1 monoclonal antibody with a topoisomerase 1 inhibitor payload and then a tetrapeptide cleavable linker. So this is a very unique agent, which actually has just received FDA approval this year for HER2 positive breast carcinoma patients who have received 2 prior lines of therapy. And I like this study and I want to highlight it because it is another potential option for our HER2 positive patients with colorectal cancer, because this demonstrated very promising results. And this was in, this allowed prior anti-HER2 treatment. Primary endpoint for this study was response rate, and this actually had 3 cohorts. So we're really going to focus on cohort A, which is the standard patient population with 3+ IHC or 2+ IHC or amplification by FISH. And they looked at 53 patients. And basically, these are the patient demographics in regards to this patient population. These were heavily pretreated patients. And keep in mind here, the response rate was quite impressive at 45.3%. Once again, small study, but very promising results. And obviously something that we should keep on the lookout for our patients that have received prior anti-HER2 therapy. And obviously the results were actually more amplified for those patients that were IHC 3+, and that's here in the dark blue, as you can see, in regards to degree of response. For progression-free survival, it was 6.9 months, And then the overall survival had not yet been reached. And really, once again, focusing on the blue, which is basically cohort A, which was the HER2 3+ by IHC or amplified by FISH. Now I'm going to focus now on rectal cancer, and we'll be highlighting three of the most commonly discussed regimens from this year's ASCO, with really just pivotal information, I think. So this is the standard way we look at our rectal carcinoma patient population. This was the original trial, the landmark trial, the German trial, noting that neoadjuvant chemotherapy with radiation treatment benefits our patients prior to surgical resection. And so these were the original results and updates, which basically demonstrated that these patients appear to have reduced risk of local recurrence. And this was after a median follow-up on the right, although the p-value had actually reduced to a lesser degree, it was still beneficial. So PERDUGE 23 basically looked at T3 to T4 N0 node positive patients, and they were randomized in a 1-to-1 fashion to the investigational arm of FOLFIRINOX for 6 cycles or 3 months, followed by chemoradiation therapy, followed by TMA, and then adjuvant chemotherapy. And adjuvant chemotherapy was recommended as part of the study. It was mandated. And the primary endpoint was disease-free survival. Now, you could receive Xeloda as an option as well. And basically in this patient, here are the characteristics of the tumors. The majority of the tumors were basically low-lying or mid to slightly high-lying tumors. The majority were T2 to T3, and 90% of the patients in both arms were node positive. And they were very compliant with their treatment. The majority of patients did complete their neoadjuvant therapy. In regards to the benefits, as you can see here with the role of total neoadjuvant therapy, there was improvement in tumor regression grade across the board in regards to YPT0, YPN0, and then for total complete response of 27.8% versus 12.1%. The disease-free survival was superior for the TNT arm of 75.7% versus 68.5%. And they also looked at metastasis-free survival, which was also improved for the total neoadjuvant arm. So once again, FOLFIRINOX prior to chemoradiation therapy appeared to be beneficial for both. Now, another trial that also garnered a lot of interest was this trial looking at distal rectal cancer. This is a very kind of unique study design because it's looking at the role of chemoradiation therapy upfront followed by chemotherapy, or induction chemotherapy followed by chemoradiation therapy. So looking really at sequencing. And the primary endpoint here was also disease-free survival, and this was reported by Dr. Garcia Aguilar. And the control arm was basically looking at historical controls. And these were the two, basically comparing the two arms, really no difference between the two arms. 70% of the patients were node positive. Looking at adverse events, no difference, once again, of the two arms. And here is the primary endpoint. No difference in regards to disease-free survival when looking at sequencing, whether or not induction versus chemoradiation therapy upfront. And there was no difference also as well as distant metastasis-free survival. But TME-free was very, very interesting because in fact, concurrent chemoradiation therapy upfront first, followed by systemic chemotherapy appeared to result in a likelihood of sphincter preservation. So there were more patients that were more willing to consider a watch and wait approach, and the capability to have a watch and wait approach of receiving concurrent chemoradiation therapy upfront. Once again, this is the distal rectal cancer patient population. And last but not least, I'd like to highlight the Rapido trial because I think it's an extremely important study. This was a phase 3 study looking at the role of 5x5 short course radiation therapy followed by systemic chemotherapy prior to surgical resection. And this trial is extremely important because there was a lot of hesitancy regarding the role of 5x5 radiation therapy because previously there had been reports of some associated toxicities utilizing 5x5 relative to long course radiation therapy. And I'm sorry, the primary endpoint here is disease disease-free treatment-related failures. Sorry. So we're basically focusing on the high-risk patient population, T4, extramural invasion, N2, and really looking and comparing the two arms demographically, no difference between the two arms. In regards to surgical complications, no difference as well between the two arms. And in regards to residual tumor, no difference between the two arms. But as you can see here in the experimental arm, higher likelihood of a pathologic complete response, 28.4% versus 14.3%. So the primary endpoint here is disease-related treatment failure, and they want to demonstrate a difference of 30% versus the goal of 22.5%. And basically, this was this demonstrated benefit for disease-related treatment failure for the experimental arm. Also, it was noted that reduced risk of distant metastasis going forward with this total neoadjuvant approach up front. In regards to overall survival thus far, no difference. And in regards to local regional control, not statistically different between the two arms. And last but not least, I just want to highlight there's a new change in the treatment for newly diagnosed metastatic anal carcinoma patients. This is based upon an international trial that I participated in, led by Sheila Rao. And I just wanted to highlight it real quickly, looking at cisplatin and 5-FU given on a standard Q28-day schedule versus carboplatin weekly Taxol on a Q28-day schedule. The primary endpoint here was response rate. And there was no difference in response rate between the two arms. This is the first randomized study looking at this patient population, but there was a difference in toxicities. There were less toxicities associated with treatment if you had received carboplatin and weekly paclitaxel. As a result, that is now considered the new standard of care that we recommend here in the United States. The PFS was trending in favor of the investigational carboplatin weekly paclitaxel, and the median OS was in favor of the same regimen. You should be aware that pembrolizumab has been evaluated on the expanded cohort study, and I just wanted to highlight this because many people are utilizing this off protocol. And I would encourage you once again, if there is a clinical trial, please participate in a clinical trial. In this patient population with metastatic disease, the overall response rate was about 11%. If you're a PD-L1 positive, it was about 15% versus PD-L1 negative, but once again, not really powered enough to demonstrate a difference between requiring PD-L1 positivity, unlike some of the other malignancies that do require it. PFS was 2 months and median OS was 11.9 months. So last but not least, I just want to let everyone know we just opened up the first phase 3 trial ever in metastatic anal cancer, the 2-to-1 randomization, exploring the benefit of the combination of chemotherapy, as mentioned earlier, carboplatin and weekly paclitaxel, plus or minus nivolumab, and the primary endpoint is progression-free survival. So in conclusion, rare subsets is a new standard of care for metastatic colorectal cancer. And that's why I encourage molecular testing up front. TNT is trending as the preferred option for locally advanced rectal cancer. And the new standard of care for metastatic anal cancer is carboplatin and weekly paclitaxel. Thank you so much for your attention.
Perfect. So much going on in GI malignancies.
Yeah,
I mean,
sorry, there's just so much going on.
I mean, it is really amazing. I mean, I actually thought ASCO this year was an ASCO GI, you know, ASCO rectal. I mean, of course, I look at it from the loving eye of a GI oncologist, if there is one of those loving eyes. But I think, you know, we have seen so many new things, which is really cool. I think, you know, it would be great to have Manju now present because, I mean, because it really ties nicely into what Dr. Eng presented. Manju, do you want to share your perspective? You know, because you know what I really like here in this really interactive panel is, you know, we talk amongst each other as experts so much, and sometimes, often, we actually don't listen to patients as much. And Manju has been very much involved. He's very vocal. Has actually helped us design clinical trials. Is a member of the Rectal Cancer Task Force, so linked to clinical research. So I really appreciate Manju's input here. So Manju, tell us what was important in 2020 for you.
Yeah, thank you. Thank you so much for inviting me to be part of the panel. So I'm just going to talk about what from my perspective, what I think was, you know, advances in 2020. Yeah, so first I want to I think the most significant thing that happened in 2020 is, lowering the CRC screening age. The U.S. Preventive Services Task Force has just issued a draft recommendation and to reduce the CRC screening age to 45. And we know that CRC continues to claim too many lives. And most recently, we heard of the passing of Chadwick Boseman, and that brought the issue of colorectal cancer as in young people to the public's attention. And this, following that, like the US PSTF draft guidelines were issued just recently, and this is a period of time where public commenting is allowed, and this will end on November 23rd. So I recommend that people watching this, please go and post your comments, and we hope that this will be finally accepted as the CRC screening guidelines. So that is I thought that was the most important thing to happen this year. And I'm going to just briefly talk about a few trials that I think from the patient perspective are important. The first one is the IDEA CRC trial. And basically they were looking at, the duration of chemotherapy for stage 3 patients. And the final results were presented at ASCO this year. So basically what it says is that for most patients with stage 3 colon cancer, they are low risk and they should just receive 3 months of CAPOX. And those, the 40% of patients are high risk, and for a majority of them, even for them, 3 months of CAPOX may be sufficient. But as we have seen in our patient communities, there are some patients who want to get the most aggressive treatment possible, even for stage 3. So in those cases, a discussion with the oncologist and then increasing the duration of therapy for 6 months is recommended. So now there are new tests like immunoscore and markers like ctDNA, which can help to define what group of patients would need 3 months versus 6 months of therapy. In this context, I kind of wanted to bring attention to this paper. It was published in October in the European Journal of Cancer, where they look at a new prognostic and predictive tool for shared decision-making in stage 3 colon cancer. I thought this was kind of interesting for patients because they have this figure, which is kind of a prediction of 5-year disease-free survival. And they have kind of categorized stage 3 into about 16 subtypes. And based on the therapy that people get, like surgery and then fluoropyrimidines and then oxaliplatin for 3 months and oxaliplatin for 6 months, they've given some percentage values to predicted 5-year disease-free survival. I thought that this figure was so important because then it helps patients to have some kind of an idea that, how much benefit do you get when you stop your oxaliplatin at 3 months versus you have oxaliplatin for 6 months. And I thought that this would be it's a predictive model, so it has its own problems, but this serves as a good starting point for the discussion between the oncologist and the patient, where they can kind of visualize the benefit that they may get by changing the duration of treatment. The next thing, Dr. Eng very nicely presented about all the rectal cancer trials. For me, from the patient perspective, I think that this is the right time for personalization of rectal cancer therapy. There are different kinds of options available. With the COVID scenario, there is now a switch to more of the short course radiation when compared to the 28-day chemoradiation. And, there are different duration of treatments for chemo. And so at this point, based on the characteristics of the patient's rectal cancer, it seems that a good discussion between the patient and the care team of oncologists, surgeons, and radiation oncologists is ideal for personalizing rectal cancer therapy. With that, I'll go to the next one. Another thing that has been quite exciting for me as a patient personally has been ctDNA tests for especially the tumor-informed ones for minimal residual disease and surveillance. I say this because I was, with my rectal cancer, my CA has never been above, say, 1.2. So for the percentage of, about 30% of patients with CRC, CA is not a very good test. And, though I was getting it every 3 months for the last 2 years, and now I'm going to start getting it every 6 months, really, I'm always worried whether, is there something else I can do? So these kind of tests are quite useful, and using these tests along with other, imaging modalities and CEA, that gives patients more confidence that they're doing the best they can to make sure that they're watching whether the disease is coming back or not. In this regard, the tumor-informed ctDNA tests are very important, and what they do is that they look at the patient's tumor and identify a unique panel of mutations, and then they use that to follow using blood biopsies to look at the chance of recurrence by detecting those mutations. So this is unfortunately, these kind of tests are more common for colon cancer, and they're lacking for rectal cancer because such kind of tissue is not available prior to treatment in the case of rectal cancer patients. So it seems that there is now a trend to make sure that for rectal cancer patients, enough biopsies are collected at the time of diagnosis so that they can use this kind of tumor-informed ctDNA test. The next thing, I kind of wanted to talk about this because Dr. Eng talked about the Anchor and the Beacon trial, and we have a BRAF group in Colin Town, and it's a very active and engaged group, and we have many patients who have tried the Beacon triplet. That has been a problem with patients is that like the duration of response is pretty short, and that the chances of I mean, many patients have very dramatic response on the Beacon drugs, but once their CA starts rising, then the disease kind of sort of explodes, and that becomes a big problem to control after. So in that regard, this particular trial from Dr. Corcoran, this was presented at the ESMO meeting of targeted therapy plus immunotherapy for the BRAF V600 patients. This is something that we are watching very closely. And so far, we think that of all the different treatments that are available for the BRAF V600 mutated colorectal cancer, we think that this might be something that may have a better duration of response, as well as chances to prevent the emergence of a lot of explosive growth once patients start not responding to treatment. So we are kind of, from the patient side, we are very interested in seeing results from this trial, and similar kind of trials with the targeted therapy plus nivolumab is going on at MD Anderson and UCSF. So with that, I think that even though with COVID, there has been a lot of issues with, like stopping of many clinical trials, I think it has been an important year for CRC patients with many important advances. Thank you very much for your attention.
Perfect, very good. So let's come back to a couple of things. So first of all, rectal cancer. And, I remember when we switched from surgery followed by radiochemotherapy to radiochemotherapy followed by surgery, and thought, oh, that's great. And now we recognize rectal cancer is actually so many different diseases, so many different treatment approaches. We recognized early on, I think, upper rectal cancer, lower rectal cancer, but now we have all the different dials that I think, Chris Hallmeyer, you really did a great job in discussing this and putting all these different switches and dials, on the table. There's not a single cancer where we have that many discussions, that long discussions or MDTs, as in rectal cancer. And because there's so many factors to consider. Cathy, what do you think?
Well, I was going to say, I didn't even show you the diagram for PROSPECT, which is currently pending, which is considering omission of radiation therapy. So yeah, I think it's exciting. I mean, I think it's a great, I'm so grateful that we are now looking at the different approaches to radiation, the different approaches to anatomic location, toxicities of therapy, as you mentioned, total neoadjuvant therapy to reduce toxicities, etc. I mean, it's fantastic.
Yeah, it is absolutely fantastic. But it also highlights the importance of expert evaluation. Right. I think this is one of those cancers. I think pancreas cancer and rectal cancer really need an MDT team, and you want to really train rectal surgeon. The rectal surgeon is also saying, I won't do surgery because we can do NOM. That is a mindset, that surgeons have to embrace too. And I think, it's a challenge for us to educate everyone about all these different treatment options that we have. And it's still not easy to integrate this in national guidelines because there are so many different factors to consider.
Correct.
And so NCCN, it seems always a little bit behind, because all of a sudden there's Opera, there's Podige, there's Rapido, and next year we'll see Prospect, and it's hard to keep up.
Yeah, and it's so, I mean, the importance of diagnostic imaging is also incredibly important in having the discussion with the patient and the treatment planning.
Yeah, and then we talk about ctDNA. How does that influence our adjuvant treatment decisions? And I can tell you from, we're all involved in some form in the cooperative group, NCTN arena, and ctDNA in its various diagnostic and treatment monitoring aspects, has been integrated in strategic priorities and aims, for almost every task force, in the GI world, because we're all excited about it. But the problem is we sometimes don't even know what to do with the result, because we don't have data to fall back on. And I see this right now in patients. Of course, everyone's excited, but what do you do with the result when you don't see a scan correlate yet? Do you treat a biomarker? And it's not easy. And
Oops.
Too long, really, because it will take years and years to generate the evidence. By that time, the next hot thing has already been developed. Manju, and I know that you are involved in some of the trial designs, even including the non-operative management trial right now.
Mm-hmm.
Okay, what else do we need to talk about? COVID. Was there something like COVID this year? Yeah, I think we all have been impacted by COVID. And when in March, April, when this whole, I think it really dawned on us, it came down with this black cloth, and all of a sudden you couldn't find toilet paper anymore, and you couldn't find, and patients didn't want to come to clinic, colonoscopies were closed. I think elective was deferred because we thought it would be done by June. Little did we know, and so, but I think we found a way to keep things going now. And I don't know, Heloisa, what's in your shop, but we've seen, I mean, we're back to where we were. We wear masks, and we might have changed our treatment approaches a little bit. But are you back where you were?
Yeah, unfortunately, Utah now is in the highest levels that it has ever been. So we kind of put a hold.
You have not turned the corner yet? You have not turned the corner?
No, it took a while. When the East Coast was with tons of cases, we're not, and now we're really in the highest that we ever been. Our ICUs are overbooked and things like that. It's not a good situation in Utah right now. So elective surgery, not for cancer, now I think is placed on hold again. We're definitely more comfortable seeing patients in person and patients the same. So today my clinic was essentially full in person, but mostly it's being 50-50. I think for the right patient population, it's perfectly okay to do telehealth, especially patients that come from too far. I do miss seeing patients in person, of course, and I think even though you try your best through telehealth, there's always something to say about being in the same room with a patient. So I can't wait for this COVID pandemic to be over. Don't know when it's coming anytime soon, but
yeah. Manju, from a patient perspective, how's telemedicine being embraced?
Oh, I think that, like I heard that in between there were some problems that they were not able to do it. But initially, I think when everybody was allowed to do telemedicine, people found that it is very useful, especially, when the trials were closed and people were scared to travel long distances. Even for clinical trial enrollment, people were willing to have telehealth calls. So I think that made a big difference to patients. And then, for example, in my case where I'm basically, having surveillance and I have every 3 months I have a visit. So those kind of things are very easily done by telemedicine. And that's what people, and you don't have to worry about going to a hospital and meeting somebody, and, you can stay at the comfort of your house and then talk to your doctor. So
yeah. So Thursday is my telemedicine day. So I block everything on Thursday morning. So I go through my patients, because I find it a little bit more difficult to wedge it into, seeing patients, in person, because we are running behind in clinic, and then the appointment is not scheduled right. And today was a great day because, technical glitches, etc. What I would like to see, though, I mean, this ties into the idea of kind of medicine, medical politics. having a national license to do telemedicine. And so that, right now we're a little bit in a, let's say, legal free zone, because when I have a patient today from New York, who called for a second opinion, and I'm treating patients in New York and making medical recommendations in New York. You know how that is, and it's you need to flank it with a lot of disclaimers, etc. So I would love to have this as a wake-up call that we need a national medical license.
That would be on my dream list. That would literally be on my dream list, because right now I'm licensed in multiple states, but they're individual licenses, right? And then, there were those temporary licenses that were allowed because of COVID, but then some states are not renewing those temporary licenses.
Yeah.
So
because
now
COVID is over, you know that.
Yeah, no, seriously, I could not believe that they were rescinding the renewals for the temporary licenses. So I agree with you completely. This has to be something that's taking at a higher level to support the role of care across state lines.
Yeah, I completely agree. Okay, COVID has impacted us. I think we found a way to manage it, found a way to run clinical research, educate people. I think people really embrace these educational, opportunities that we have now. I mean, people call into these meetings, and hopefully people benefited from our interaction here. Highlights GI updates 2020. I think it was great. Hopefully more to come 2021. Hopefully with a COVID vaccine. Yeah. Let's cross our fingers. But I know we all know it will take some time, and it'll be a long road. But hang in there. We're resilient, and there is hope. Okay. Thank you, everyone. This is great. I really enjoyed it so much. Yeah. Take care and stay safe.
Thank you so much.
Okay,
Thank you very
bye-bye.
much.